If you are a psychology student in the final year of your bachelor's or master's program, you already know this is coming. Your mandatory internship. You might be placed in a psychiatric hospital by your university or might have to choose one yourself. Some of you may also find yourselves in private psychiatric clinics. Wherever you go, the purpose is the same. This is your first real exposure to how patients with mental health conditions, early stage or advanced, are actually treated. So, in today's video, I want to help you orient yourself to that experience based on my own training across 2 to 3 different places. I moved because I wasn't fully satisfied with the exposure in one setting and wanted to understand where real learning happens. All right. So, what I'm sharing is not theory, it is lived, practical experience. I'll keep this neat and simple so you can easily digest this. So, the core objective of your posting in a psychiatric facility is observation and training, especially in case history taking and mental state examination. These two form the backbone of clinical psychology work. Along the way, you will probably be exposed to tools like Vineland's social maturity scale, 16 personality factor, Beck's depression inventory, and so on. Whether you get hands on exposure to projective tests like Rorschach depends entirely on the institution. But case history and mental state examination, those are non negotiable. So now let's start with case history, right? A good case history reads like a coherent story, not bullet points stitched together. It is a psychological narrative of how a person's life, context, relationships, stressors, and vulnerabilities, have shaped their current distress. Now, here is the practical reality. In real clinical settings, there are too many case histories to be taken. Time is limited, workload is high. So, people often resort to bullet points, right? Operationally, that makes sense. But understand this that when someone else is taking your case history, bullet points can feel minimizing. They flatten lived experience. They remove sequence, meaning, and emotional texture. So, the skill you need to develop here is balance. Even if your notes are structured, they should be so clear that when you present them to a senior psychologist, they understand the patient without you having to explain or defend your notes verbally. During your internship, especially early on, you are not in a rush. You usually have time. Use that time to practice writing the case history as the person tells it, not as you immediately interpret it. Capture their words, their emphasis, right? Their sequence. Interpretation comes later. First, let the story exist. Now, coming to mental state examination. This is something I absolutely loved. Mental state examination brings together observation, thinking, and clinical reasoning. And at the end of a good mental state examination, there are three components that matter deeply, at least to me: provisional diagnosis, differential diagnosis, and therapy planning or management. Together, this is often called case formulation. If someone asks you how to formulate a mental state examination, you don't need fancy language. You can say this clearly. You arrive at a provisional diagnosis, you consider differential diagnosis, and based on these, you plan management. Because you are a trainee, this is your opportunity to slow down and think. Once you have filled out the mental state examination, sit with it. Open the DSM or the ICD, whichever you are using, right? Compare what you observed with the diagnostic criteria. Ask yourself whether what you are seeing actually meets the threshold and where it does or does not. This is how confidence in provisional diagnosis develops through correlation, not guessing, okay? Now, differential diagnosis is simply the next best explanations after your provisional diagnosis. If your provisional diagnosis is priority 1, your differentials should be priority 2, 3, 4, and so on in order. Order matters. And why do you even need this? Because mental health diagnosis unfolds over time. Often we only know whether a diagnosis was accurate after observing treatment response. Sometimes diagnoses change, not due to incompetence, but because new information emerges. Reformulation improves outcomes, right? That is how the field works. Now, let us talk about hygiene and boundaries. When I say dress simply and professionally, I mean this very literally. Do not wear loud or bright colors. You are in a psychiatric setting. Some patients have sensory sensitivities. Bright colors can overstimulate, agitate, or emotionally clash with their internal state, right? Colors carry meaning. They charge environments in a serious clinical space, especially when you do not yet understand the emotional climate. It is the safest and most respectful to wear muted, neutral colors. This is not an extension of college life, right? Do not keep your hair casually open. Do not wear bright lipstick. Do not experiment with fashion. Dress down. Be unobtrusive. And now, boundaries. Never get physically close to a patient, no matter how emotionally attached you feel. You do not know the patient yet. You do not know their triggers, their attachment patterns, or how quickly emotional needs can escalate. Maintain physical distance always. Psychologically as well, do not over identify. Do not disclose your personal life. Do not talk about your struggles. So, what feels like being human can quickly become clinically inappropriate and never promise outcomes. You do not know how treatment will unfold. Finally, ethics. This is non negotiable. Do not discuss patients outside the clinical setting, not with friends, not with classmates, not casually. Comments like, I saw a patient like this, he's so cranky, or I think they are just there for drama, are absolutely not acceptable. Not everyone in a psychiatric hospital is there only for mental illness. Some are there for legal or protective reasons too. Okay? That is none of your business to comment on. Loose talk spreads. People mirror behavior. What you say can travel and turn unpleasant very quickly. There are also real consequences. Supervisors notice patterns of conduct. Negative feedback reaches your university or your college. Your professional reputation can be damaged before your career even begins, right? But beyond consequences, this is about integrity. You are training to become a psychologist. Being dismissive or mocking of patients makes no sense in this field. I saw this behavior during my own training and I strongly disliked it. Ethical conduct is not optional, it is not situational. It is a line you do not cross. Internship is not about showing brilliance. It is about learning how to stand steadily in clinical spaces without collapsing or inflating. That capacity, that presence is what stays with you long after the internship ends. There is actually a lot more to psychiatric internships than what one YouTube video can cover. So either you do your own research and learning, or if you want my guidance, especially on things like preparing your internship file and developing cases coherently, you can book a session using the link in the description. So that is all for today. Thank you for watching. All the best.